It really is a great honor, and it actually is a great moment for me to receive this honor. This has been a big year of transition for me, and I really appreciate that I can be here today and give the talk. So I did want to begin with this. I'm actually required to begin with this disclaimer to just confirm for all of you that I did fully retire from the US CDC in April of 2025. So everything I'm going to say today is just my own opinion as a private person, and it's all based on publicly available information. And I also wanted to take the opportunity to give some thank yous up front instead of at the end, because it's unusual that I have such a holistic opportunity for thank yous. And they are going to center on Carol Baker, but they need to begin a bit earlier from another inspiring woman scientist when I was a child. We don't often thank Jane Goodall at the ISSAD conference, but she is really the reason I became a scientist, and she gave me the courage actually to pursue my passion at the time, which was to study the mysteries of animals. I also want to give a thank you to this snail. Anyone in the room from West Africa and particularly Nigeria may recognize this as a schistosome vector snail, Balinus truncatus. And I spent, please go back one. I spent 4 years after college studying this snail, and I was not interested in the least in schistosomiasis and its effect on humans, but in the effect of the parasite on whether the snail chose to self-fertilize or cross-fertilize. And so I was fascinated by this question, but thanks to the snail itself, while I was in the Kano area in Nigeria doing some field work, I started to get the epiphany that I might actually be interested in helping humans as opposed to learning about snails. And so that motivated me to move forward a little bit in that exploration, and I had a natural gravitation in my own life towards helping babies get a healthy start. And I did not have a life-threatening condition when I was born, but I did have severely crossed eyes, which led to a lot of concern, and initially was difficult to diagnose and resulted in quite a few surgeries when I was a baby and a child. And from that, I've just always had this appreciation that it's really important, if we can, to give babies and their families a healthy start free of medical anxieties. And so I took those two interests to make a little bit of an evolution of my own. And so I went from my snail work at the Department of Zoology in Oxford and took a step towards helping humans by going to a postdoc at Emory University, where I studied the evolution of antibiotic resistance in E. coli bacteria. And from there, a couple years later, I actually walked up the street to the CDC and went full-on public health. And that is actually what CDC still looked like in that time. And you can see that I was not really architecturally blessed in my career, but I was very blessed in terms of mentors and role models. And so that brings us squarely now to Carol Baker, and where I have my thank you for Carol. I was lucky at CDC that I landed in the group that was responsible for a range of things, but including Group B strep. And my very first project at CDC was on Group B strep, and none of my career would have been possible without Carol's pioneering work in the field and also her just ongoing championship and advocacy for child health during my whole career. I was looking for a photo of Carol, and I was so pleased when I found this one, because I know that Carol really wanted and intended to be here in person at this conference. And I think this photo lets us all together take a moment now to picture that Carol is actually sitting here among us. And if she were here, I think some of the time you'd see this smile on her face. But you would also see a sterner expression, and you might hear some important questions asked and some maybe strong opinions voiced if she were here. And so for the rest of the conference, I'm hoping that all of you can channel your inner Carol, and let's start to hear it coming out. So next slide. I do also want to think I had wonderful mentors when I was at CDC, in particular Ann Schuckett, who was the founder of CDC's Group B Strep program, and Cindy Whitney, who was my boss for a couple of decades, really. Both were so supportive of my efforts to grow and shape the Group B Strep program. I also want to give a shout out. There are a few of my former CDC colleagues. They're still at CDC. They're here today. They're in the room trying to keep the Group B Strep program going, and I'm so grateful to them for their steadfastness in what has been a really difficult year. I also want to thank the many friends and alumni of CDC who for more than a year now have been conducting weekly protests and who have been really fighting to try to save CDC, to more broadly try to save public health and science in my country. And we're going through a very difficult phase, and I'm grateful that there are so many dedicated people trying to keep the work going. I was thinking that what I could share with you that might be useful today is I entered the Group B Strep space in a time when intrapartum antibiotic prophylaxis was still a young intervention, and we learned a lot of lessons from that experience that I think might inform the road ahead now as we think about a maternal vaccine. So I wanted to share some lessons that might help all of us as we look forward. To do that, we have to go back to the distant past, and gratefully, I could not find any photos of me in my college days, which is really as far back as we need to go, but these are some photos from my snail hunting days, and I thought it would be fun to share these. While I was in college and while I was out in the field hunting for snails, there were some important Group B Strep advances occurring. I didn't even know Group B Strep existed at this time. But in the mid-1980s, there was a randomized clinical trial of intrapartum ampicillin that was actually stopped early by the Data Monitoring Committee for overwhelming efficacy against early onset Group B Strep disease in the first week of life. And a couple years later, this result was confirmed in an independent Australian cohort study. So based on this, in the early 1990s, the US obstetric and pediatric professional societies both released their first Group B Strep prevention guidelines for use of IAP. But interestingly, at this point, there was not good agreement, and some of you may be familiar that sometimes obstetricians and pediatricians don't see eye to eye. And this was another of these instances where there was not agreement on the best way to identify women for IAP, and the pediatricians preferred to screen women for Group B Strep colonization before delivery. And the obstetricians at that time were preferring a more risk-based approach, monitoring women who presented in labor for certain risk factors. It was really because of this controversy, this disagreement, that public health came onto the scene, and my former boss, Ann Schuckett, a younger version of her shown there, got involved to try to get consensus between the pediatricians and the obstetricians. And Carol was also instrumental even at that phase, although she did have very strong opinions, as you can imagine, about what the guidelines should be. And Ann did an amazing work of diplomacy here, where this first guideline essentially recommended either the approach that was really favored by the pediatricians or the approach that was favored by the obstetricians as equally acceptable. And we were at that stage in terms of evidence in equipoise. There really wasn't enough evidence to prefer one strategy over the other. But the watershed moment with these guidelines was that at this point in the US, clinicians needed to use one or the other of these strategies. So if they were not implementing Group B Strep prevention at all, they were subject potentially to litigation, and that's in my country at least, where there's a lot of teeth and you can get people to do things. The work of those guidelines, and really ever since then, also wouldn't have happened without the power of the parents. And I just want to pause to acknowledge them. It's been so meaningful to me at these ISSAD conferences, the way the parents are fully integrated in the conference. And I get teary whenever I hear the parent stories. I just did in the lead-in to this talk. And I'm showing some of the more modern versions of the parent groups, but there have been different evolution there and incarnations, and all of them have been important. I know that there is still one box somewhere at CDC of letters from the public and mostly from parents that were sent in 1995 at the time of the first guidelines meetings. So thank you, parents, and keep it up. So a first lesson is that in the US with IAP, public health really only established a Group B strep dedicated program once there was an effective intervention identified. Before that, it was a problem, a health problem, but it was really viewed as a clinical problem and not something for public health. And I think the implications for a maternal Group B strep vaccine are that as we get closer and closer to a vaccine, this may be the moment when countries start to create Group B strep programs now or strengthen the start of those programs. And I think that's really important. And the parents, I want to remind you, there's never rest for the weary, but I think this is a time when parent advocacy and demand generation is really critical. And I want to say that even in the US, where we have more mature Group B strep prevention right now, we do also in our country have a very virulent strain of anti-vaccine voices, and many of these are coming from parents. And so I would like to invite parents that have a different perspective and maybe have had personal experiences with infections and want to protect future babies to try to get a loud voice in my country in particular right now as a counterpart to some of the voices that we are hearing. So those guidelines came out in '96, and I walked up the block to CDC in 1998. And a lot of you probably weren't even born in 1998, so I just wanted to refresh your memory what that was like. We were all a little intimidated by a new version of Windows that had come out, and France won the World Cup. There were a few technologic and scientific advances that year, and at that time in the US, there were some headlines that were catching a lot of attention as well. What I had in my mind was a different set of questions, and we were very early at that time in the IAP era, and as I mentioned, even my very first project at CDC was related to Group B strep, and we didn't know much beyond the clinical trial findings at that point. So we were wondering what would be the real-world effectiveness of IAP, and also how might we best target women for prophylaxis if we were going to look for Group B strep colonization. We didn't even know the best way to do that. How should it be measured? When should it be measured? If we were going to focus on obstetric risk factors, what should those risk factors be? And then we didn't know with IAP what the implementation feasibility would be or the acceptability. And we were worried about unintended consequences of the strategy. Another question we wondered about is would this have any benefit for late onset disease? And we didn't know at that point. I just want to pause and point out right now that those questions came up for IAP, but I think versions of these questions will really also apply to a maternal vaccine, so they're relevant for us all to think about now. So the foundation to address these questions in the US was an invasive Group B strep surveillance that CDC had established, and I'm pleased that this has been mentioned multiple times already today, the Active Bacterial Core Surveillance Platform. And this platform allowed us to track disease trends and also to characterize disease-causing strains. And it provided a platform as well that we could periodically do more in-depth studies where we characterized all births so that we could look at not only cases but other healthy infants in the population. This is just one example of the value of this kind of sustained population-based surveillance in the US. And using the ABCs, we could do a very simple before-after disease trend story, and it basically tells the main IAP story in the US. If you look at this graph, I have year on the x-axis, and then we have cases per 1,000 live births on the y-axis. And early onset disease is shown in blue, and late onset disease is shown in orange. And in this period of the 1990s, when IAP was being implemented and prevention recommendations were coming out, that's when we saw more than 80% drop in the incidence of early onset group B strep disease. And unfortunately, the late onset disease was not affected by the strategy. Surveillance is great, and in the US, I think we've been lucky, but I want to emphasize, because we have people here from a lot of different countries, that surveillance is not the answer, in my mind, in every setting. So there were conditions in the US that were very favorable for invasive group B strep disease surveillance. And in particular, virtually all births in the US are happening in a hospital, and they tend to have a 24 to 48 hour stay after birth. And this is an important time window, as we've all heard, for early onset group B strep disease. Infants, even once they're discharged, have good access to care. Typically, people will bring an ill baby back if they get sick shortly after birth. There's a low threshold for taking blood cultures in the US and for collecting cerebrospinal fluid when it's warranted, and that's very helpful for group B strep detection. And the micro labs are generally well supplied, and they have the right skill sets as well to isolate and identify group B strep. So all of this is what allows the invasive disease surveillance to be successful. But I know that this is not the case in many settings, and I think we've also seen a couple of times today to the right this figure that Joy Lon and Anna Seal developed that shows that when you're missing these kind of factors at each stage, you will have a loss in your detection of the group B strep disease burden. And sometimes that loss could be so severe that countries might think they don't really have a problem. I had some personal experience with the challenges of doing this kind of surveillance when I had the opportunity and really the honor to be the co-PI with Dr. Shamir Shaha on the etiology of newborn infections in South Asia, the ANISA project. And this was a study where we had surveillance sites in Bangladesh, Pakistan, and India, mostly rural sites, but we had one urban site. And we had a birth cohort of about 85,000 pregnancies. And this was a special study. It was funded by the Gates Foundation, although I think it may have predated Anna's tenure. But so we had resources, and we invested in training community health workers and helping them recognize the potential signs of illness in babies. And we had an intensive visit schedule where they were supposed to visit every baby on the day of birth, plus 2 other visits in the first week of life, and then 1 visit in the following weeks up to day 59 of life. And community members also were trained on how they could self-refer if a baby got ill in between visits. But despite all of this extra intensive effort, there were real challenges in reaching the newborns in the first week of life in this study. So 44% of the births occurred at home and didn't have a skilled birth attendant present. 12% of the births we weren't able to reach in the first week of life at all. That's when all of the early onset disease would have happened. 10% weren't reached in the first 72 hours. And again, you're really missing early onset disease if you miss those days. And 31% of babies didn't receive all 3 of the week 1 visits. Surveillance can be tricky, and I don't want to put all of that challenge on the low and middle income country settings, but even in the US, there are some forms of surveillance that we have not been able to establish. And I know this tortures some of the people in this room, and it has tortured me, but to date, we don't have surveillance for group B strep associated stillbirths or maternal infections or group B strep associated preterm deliveries. And these are important endpoints, and without there can be sometimes targeted special studies, but we really don't have these systems in place. The primary barrier, there are a variety of reasons, and we heard Anna and others discuss some of these earlier today, but the primary barrier in the US is that the relevant sample collection and laboratory workup is just not performed as part of routine clinical care. So if you're not dumping a lot of resources into this, it's not happening. And I did just in this context, in the next slide, want to give a little kudos or shout out to CHAMPS. We haven't cracked this nut in the US, but CHAMPS has figured out how to do this in low and middle income country settings, multiple of them, and it may be more than 7 now that I listed here. And so sometimes there are things that work better in low and middle income country settings. So the lesson that I would take here around surveillance is that it is of great utility when it's feasible, but it's only feasible, unfortunately, in limited conditions. And I think the implications for a maternal group B strep vaccine are that now is definitely the time for countries that are capable of group B strep surveillance, that have the right conditions that are favorable to strengthen their platforms. But settings that don't have those conditions, what I would favor in that situation is that they start to plan on how they're going to rely on data from other countries or from modeling data for their region, or maybe to find out if there might be multi-country special studies they could become a part of. But they're going to have to make a different plan, and I think it might not make sense everywhere to be setting up your own surveillance system. Even with the kind of surveillance that we had in the US, there are real limitations with just straight up case-based surveillance. And I'm going back here to this before-after trend that I showed you before for IAP. And I personally think this was only so compelling as it was because we had such a big effect on early onset disease. You couldn't miss it. Like, you all can just look at it and see it. And because we had almost no detectable effect on late onset disease, so it could tell a clear story. But there might have been an important public health value to IAP, even if it were less effective than 80 or 90%. And we might not have been as convinced if we just had a before-after analysis as to what was going on. In this kind of situation, we learned in the US that there was real power in a periodic population-based birth review inside the same surveillance catchment where we were looking for cases. And this allowed us to compare cases to non-cases. It let us have a whole birth cohort for analyses instead of just a case-only cohort. And we were able to leverage this kind of design to compare head-to-head the risk-based and microbiologic screening-based approaches for IAP, and also to actually evaluate and estimate the effectiveness of IAP in the prevention of early onset disease. This is showing you an example of the analysis we did that motivated the transition to universal screening in a cohort that was described just a couple of years after the 1996 guidelines came out. We were able to show that mothers who were managed by the screening-based approach, their babies had a greater than 50% less risk of having an infant with early onset disease compared to deliveries that were managed by the risk-based approach. And we could actually use this cohort data to dig in a bit more, and we could show that the reason for this was that a meaningful portion of deliveries to colonized women didn't present with risk factors, so they couldn't be detected by the risk-based approach. But in addition, we showed that women who were group B strep positive on their antenatal screening were much more likely to get the IAP than women who presented with risk factors during labor. On day 3, there's a morning plenary where I think we're going to get to hear US, this is all observational data, but UK, I think, has actually done a randomized controlled trial that compares risk and screening, and I'm really looking forward to hearing more about that design, and I'm not sure if they're at the analysis stage yet, but I think this will be a space to watch for people interested in this question. So this is an example of the effectiveness estimates that we were able to get for IAP. And this is really, we were using a cohort, but methods similar to what might be used if you're thinking of a vaccine effectiveness study, just using IAP as the intervention. And what I can show you here, this was done in a cohort that we collected just after the universal screening guidelines went into effect. And we saw very high effectiveness of IAP among both term and preterm newborns, the top 2 rows. So this gave us confidence that IAP does work even in preterm deliveries, which is really important. And then we also dug in and looked at different regimens of IAP. And we showed, if you look at the third estimate, that clindamycin was really not a very good IAP agent. It's an agent that we try not to use unless there's really no other option. And we also showed that the 4 or more hours of a beta-lactam that are recommended really do make a difference, and you do want to try to get in those 4 hours if you can in terms of effectiveness. And then I just wanted to share with you a most recent enhancement to the population-based platform that we were able to introduce through a study where we partnered with state newborn screening programs, and this allowed for the inclusion of remnant newborn dried blood spots as a sample type in the surveillance catchment. And this, for the first time, let us do seroepidemiology, serology on blood, which was a sample we didn't have available before. And I'm showing you here the publication that came out from the first study that used this approach. And we have one of the lead authors from that study, Julia Rhodes, here in the room. So you can definitely talk to her about that study. And if you go to the next slide, I'm also going to have the chance tomorrow to tell you in more detail about this study for people who are interested in that. Next slide. So lesson 3, what we take from these effectiveness questions related to IAP is that we probably should anticipate a family of effectiveness questions if we have a maternal group B strep vaccine as well. And some of these may require creativity and take some time to actually accomplish. It's not just a cookie cutter exercise to think about how to evaluate an intervention. And the implications for a maternal group B strep vaccine are that now is really the time that we have to start planning and designing these effectiveness studies. And also we have to prioritize the questions that will be the most critical for informing policy, because there will probably be a bunch of them, and there are some for IAP we're still answering today, years on in. So once you have a good intervention, or even a medium good intervention, you want to start understanding how well it's being implemented, because nothing will be accomplished if it's not implemented well. And we used our cohort approach similarly to try to look at the implementation of universal screening once that guideline came out. And what we were able to show in Figure A is that just in the 2 years after the universal screening guideline came out, across our surveillance areas, there was a dramatic increase in the proportion of births that had antenatal group B strep screening performed, and it went up to more than 80% quite quickly. In the figure over on the right, we also showed that the proportion of women who had an indication for IAP who received it increased as well under universal screening, as we were hoping. We do, in the US, have some persistent areas of implementation challenges, and these were described already shortly after universal screening, but they persist. The main one is around preterm deliveries, which contribute the most to the remaining disease burden that we have in the US now. And the most common missed opportunity here is a failure to administer IAP. And sometimes there isn't an opportunity, but sometimes there's just a lot that is distracting around a preterm delivery, and the IAP could have been given but gets missed. Can you go back one slide? We also have had challenges around giving the best agent that we can to pen-allergic women, and there has been some reluctance among clinicians to give cefazolin even when it may be a safe agent for a subset of these women. And women with inadequate prenatal care also have been challenging in terms of both they may miss the opportunity for the antenatal screening, but they also seem to miss the opportunity for IAP even when they present at labor. We have feasibility challenges in the US, but there are also feasibility challenges, I know, for IAP in many LMIC settings, and Ziad mentioned some of these earlier, and I do think there may be some more discussion of this also on that plenary on day 3, so I'm encouraging all of you not to skip out to the safari until ISSAD is over. But if we go to the next slide, in most LMIC settings, antenatal microbiologic screening is just not practical, and certainly not outside the context of a special study. And there is some potential for risk-based approach during labor, particularly in hospitals that are able to do that. But there may be barriers even in these instances. So we know it's a non-starter to do intravenous antibiotics for home births, but even many women who deliver in hospitals in a lot of settings present late in labor, and they may not have the opportunity to get these 4 hours of the antibiotic. And even if they are there, there can be challenges with having sufficient supply, with having enough qualified staff to safely deliver the antibiotic. And Ziad mentioned earlier all the cost challenges associated with this. And so we do have real challenges in LMIC. Because of this, I've been one of the people, but I think there are many, including some in this room, that have tried to explore, could there be alternatives to IAP that would be practical for low and middle income countries? And one of my first global collaborations, I was very honored to work with Claire Cutland, and that was my first project with Shabir's group. I didn't know at that time they were going to become the groupie strep powerhouse that they became, but we evaluated the efficacy of chlorhexidine vaginal washes given during labor in preventing group B strep infant disease. And there was some observational data out of Malawi at the time that motivated this trial that suggested it could be a very promising approach. But unfortunately, this trial, I think Claire and I liked to say that we confirmed that chlorhexidine was no better than water. It just didn't work. I also had the opportunity to be on one of the trial committees for a trial led by Dr. Ana Roca that was looking at single-dose azithromycin intrapartum to try to prevent a range of outcomes, including neonatal sepsis, and unfortunately we didn't find any evidence of efficacy against that endpoint. In the US, there have been a few hospitals that were very interested. They served populations that didn't have good access to prenatal care, and they were very interested in exploring whether giving a postnatal intramuscular dose of penicillin to babies, ideally within an hour at birth, might be effective at preventing group B strep disease. And this intervention alone found no real evidence against preventing infant disease. When combined with a risk-based maternal approach, it does show in observational data some potential, but now we're in IAP territory again, like we're combining IAP with this IM penicillin. People also have always been looking to giving antibiotics antenatally before labor, and could that work? And it just hasn't been shown to work, so unfortunately that's not a way out. Implementation feasibility, the lesson I take is that it's going to be trickier for some groups, and it's going to be trickier in some settings. And implications for a maternal group B strep vaccine, I think we all hope that vaccine will be more feasible than IAP for LMIC. We do have maternal vaccines in use in LMIC, and so that's a great head start. And I think now would really be the time to focus on demand generation and planning for implementation challenges. And as with IAP, it's my prediction that reaching preterm deliveries with a maternal vaccine may be the most challenging and probably requires some thought already. I myself am not really an implementation expert, as many of you in the room are, but tomorrow and the next day we're going to have a lot of discussions on this topic, and so I think we're all going to learn together about planning for implementation with a maternal vaccine. So finally, it's important, even if you have a good intervention, or maybe especially if you have a good intervention, there are always going to be concerns and people who are worried that it may be doing more harm than good. And this has certainly been the case for IAP. And so we've spent quite a bit of energy in the US monitoring for potential unintended consequences of IAP. And the biggest threat to IAP would be the emergence of beta-lactam-resistant group B strep. This would threaten not only the prevention strategy, but also treatment. So we again used our active surveillance to try to monitor for this, and I'm showing you here some work by my former colleague Moako Kobayashi, again using the active surveillance data, and the x-axis here is year, and the y-axis is showing us the proportion of isolates that have reduced beta-lactam susceptibility. The green line that you see is the very rare proportion of strains that actually are at that non-susceptibility threshold. And then the blue line are strains that have some reduced susceptibility but haven't met the criteria of non-susceptibility. They do have changes in the penicillin binding proteins. So can you go back just quickly when what worried us at the time, the reassuring thing is these are extremely low proportions, mostly below 0.4, 0.5% of strains. But what worried us at the time was this blue line that looked like it was creeping up. And it sounds from current looks at the data that this hasn't continued to creep up. But I think as an evolutionary biologist, we can never rest easy. And we know that bacteria are always evolving. So this has to be watched. We also were worried in terms of IAP with the potential effect on other causes of early onset sepsis. And in particular, there are pathogens out there that are ampicillin resistant, for example, and those have raised specific concern. So to track this in the US, we set up a surveillance that was for all-cause early onset invasive sepsis. And I'm showing you here some data that is in the era of widespread IAP. The purple line at the top is showing you the invasive sepsis due to all pathogens. And the blue line is the group B strep sepsis. And the gold line is E. coli sepsis. And E. coli is our number 2, and in some settings, our number 1 neonatal sepsis pathogen now in the US. There is a lot of ampicillin resistance, and so we were very worried about potentially causing increases in E. coli. And what you can see here is quite reassuring so far that there isn't a hint of changes in E. coli in this era of widespread IEP. We were further concerned because E. coli is really a big problem for preterm and very low birth weight infants, and it might be that looking at the overall trends is swamping out what might really be happening in this disproportionately affected group. So here I'm showing you on the left the preterm plot, and then on the right the very low birth weight plot. Again, the gold is E. coli and the blue is group B strep. You can see that E. coli dominates group B strep in these subsets, but it doesn't appear like we see a concerning trend in terms of increasing incidence rates. Another set of concerns, and this was a newer kind of concern that has emerged as the understanding about the microbiome has also grown. And people have worried that there could be really lasting consequences of disruptions of the microbiome due to this IAP exposure at birth, which is right when babies start to establish their microbiome. And many outcomes of concern in this context have been hypothesized, including childhood weight gain, gaining too much weight, allergy concerns, and concerns about increased risk for certain kinds of infections. And I had the opportunity to collaborate on 2 independent studies that were evaluating the childhood weight gain outcome. And I do want to give a shout out that a couple of the co-authors from one of those studies are here at ISSAD, Karen Popolo and Sagari, and you should look for them. Sagari just gave a presentation earlier about, I think it was today already, about the microbiome. But both of our studies found a modest but statistically significant effect at 5 years of age. And in the California cohort, they were able to actually look out to kids who at 10 years of age. And interestingly, this small increased weight gain persisted at that age. But we don't really know what it means. The increase in weight was quite small, and so we still don't understand implications directly for overweight and obesity. So here, I just wanted to help us all anticipate unintended consequences of concern related to a maternal group B strep vaccine, because I think these are worth thinking about. Direct concern is always adverse effects adverse reactions to the intervention. And with IAP, the blessing that we had there is that these were very familiar agents where the allergy and anaphylaxis risks had been well described, and we haven't really had any surprises on that front. But with a new vaccine, there's going to be an intensive engine focused on understanding the safety of the vaccine and the associated adverse events. And that started already with the phase 2 work and will continue with the phase 3 trial, but is going to extend well into the period post-licensure. And I think we'll hear some discussions about how we'll monitor for that tomorrow. With IAP, we worried about the emergence of antibiotic-resistant group B strep. And with a maternal vaccine, we worry sometimes about vaccine escape strains. And for some of the pneumo people in the room, you know about the risk of capsular switching or other recombinant events that can happen and make a vaccine less effective. And we'll have to watch for this with group B strep. For IAP, we worried, as I just mentioned, about a potential increase in other causes of neonatal sepsis once we bring down the group B strep. And I think it is possible that an analogous concern could arise with a maternal group B strep vaccine. I think this would mostly come up if the vaccine ends up being effective at reducing maternal and newborn colonization. And people might start to worry, is that leaving a vacuum for some other pathogen to come in, and maybe that will be a bad bug. IAP, I think the unique to IAP concern is really this microbiome disruption. I don't think that will be quite the same for a vaccine. And unique to a vaccine, we have to start thinking about inhibition or blunting of the effectiveness of other maternal or newborn vaccines that might be administered. So in particular, if we think about the GBS6 vaccine from Pfizer that's in phase 3, it's conjugated to the CRIM carrier, and there are other vaccines that newborns will be exposed to that are conjugated to CRIM, and I think those are studies that will need to be undertaken. So in terms of unintended consequences, I can assure you that these will be of concern. They probably already are of concern, and that there may be many to consider. So this, again, as we think about where we are today, now is the time to start planning and designing these relevant evaluations. And I want to point out that these may extend beyond just group B strep to other maternal and newborn concerns. So I decided 5 lessons is enough for any one talk. But I did want to touch on, there is some new territory that we will be new if we have a maternal vaccine, which is what would that mean for IAP and for countries that are using IAP? So if we go to the next slide, I personally think there's real potential for ongoing value of IAP, especially initially in the early time after a vaccine may become available. And this is because for unvaccinated women, IAP provides a safety net. It can be administered to women who refuse vaccine. We have the risk-based strategy that can be applied to women who maybe didn't have prenatal care and would never have had the opportunity to be offered the vaccine. But even for vaccinated women, I think IAP may provide added value or a sense of added reassurance. We know that IAP is equally effective against all serotypes, and in the US, early onset disease does present with more diversity of serotypes than late onset disease. IAP is highly effective for preterm deliveries, and we're not sure yet how well vaccine is going to protect those deliveries. And starting off, at least, the effectiveness of IAP is well established, and we may still initially, in the early time after a vaccine is rolled out, have some unanswered questions because of the likely licensure on immunologic endpoints. We may start off feeling like we need to keep the screening and IAP going, but would we need to keep it going forever? And again, I'm just sharing my personal opinions, and there would need to be very careful policy decisions. But my thought is that this is not necessarily the case, that we're stuck with this forever. And in particular, I think if we can start to get data on the serotype-specific vaccine effectiveness against early onset disease, if the vaccine performs well against the serotypes included in the vaccine, they cover the vast majority of early onset disease, and that would be very reassuring. I think also if we can get some effectiveness data that shows that the vaccine does protect preterm deliveries, that there's enough opportunity for transfer of maternal antibodies to the newborns, even in these preterm cases, that they have protection, that would be very helpful. And we'll be very interested to watch and see if there's an effect of the vaccine on outcomes other than early onset disease, because IAP is quite narrow in its scope, and the vaccine may work against late onset disease and other outcomes, and that will also really influence choices. So finally, I just want to end with a cautionary note, because I think this note applies to all countries, high income and low and middle income countries. We're all very excited about maternal group B strep vaccine, and some of us have spent 25 years hoping for one, like me. But IAP to date is the only proven strategy that we have right now for infant group B strep disease prevention. And while we prepare for a vaccine, I think it's so important that we don't stop our efforts to try to optimize IAP implementation wherever we can. We can save babies now with IAP, and we may be missing opportunities to do that. And I think we also should not stop exploring whether and how IAP may be feasible in LMIC. And I was pleased in Ziad's comments earlier today to hear him say that he thinks that there are some missed opportunities even in LMIC to do better with a risk-based approach and reach more babies, and I think that's really important. I just want to end with some acknowledgments, and there are too many people to thank by name, but I just feel so honored to be here today. I've collaborated with a lot of you in this room in one way or another, and you've made my career richer, and I'm so grateful. And I also wanted to thank, I've had a big transition, and I loved my team at CDC, but I do also love my current team very much. And he's been very loyal and supportive as I've gone through the transition. And he's spent most of my retired life sleeping through my working days. And so if any of you felt the need to take a short nap during this presentation, Zane wants to tell you it's perfectly okay. So thank you.
Stephanie, first of all, my comment is that was a real tour de force. I think you've set a very high bar for any recipients of this award in the future. I wanted to just go back to one comment you made about neonatal administration of penicillin. As you know, in the 70s, I happen to have trained at Mount Sinai Hospital in New York, where that was used for gonorrhea prophylaxis, and they really did not see group B strep. And George McCracken at Parkland Hospital and Jane Siegel then did a randomized trial that did show effective penicillin. So do you see that being an option in LMIC settings potentially where IAP is not feasible?
So are you talking about using the IM penicillin alone at birth, or are you talking about my understanding of the Parkland experience, but you may know more, is that they evolved from trying to just use the injection close to birth to doing some risk-based maternal screening and then giving all babies the IM pen, and they got better results with that second strategy. I feel nervous from my interpretation of the data to use IM pen alone, but if it's that or nothing, like if we're in a do-nothing situation in LMIC and there's access, I know in the US at least we have some access trouble with that formulation, but if there is access, I think it might be better than doing nothing.
Okay, it's cheap. Yeah. Okay. Thank you.
Thank you very much. Thank you, lady.
Hello, everyone. My name is Rashidat Yusuf. I'm a pharmacy researcher from Nigeria, and I'm presenting a study on GBS awareness among healthcare trainees. During the course of our study, we observed that healthcare workers' preparedness and their awareness is a very significant factor to achieve implementation outcomes, like significant implementation outcomes. So my question is, as we draw closer to the licensure of maternal GBS vaccines, are there parallel efforts being considered to assess the preparedness of healthcare workers as part of implementation planning? Thank you.
Yeah,
Thank you very much.
Thank you. And I think healthcare workers are a really important piece of this, and you're making a really good point. And I think we're going to hear more tomorrow and the next day about the efforts that are planned around this. And we have some head start around some of this by the experience with maternal RSV vaccine, which is paving the way for some of what might also benefit a maternal group B strep vaccine. But there are others with more expertise than I have about what the preparations are in LMIC, and I think we're going to hear about that tomorrow and the next day.
Thank you very much.
Yeah, thank you.
Thank you very much, and then we'll get our last question here.
Stephanie, thank you very much for your talk. I'm like an infant to the GBS community. I'm a bioengineer chemist, and we have been developing a point-of-care diagnostic test that can be used in labor wards, similar to a COVID red kit. So say hypothetically, if that capability becomes available, where we can just test it before IAP, how do you think, based on your experience, could it influence and fit into the vaccine strategy and everything else that's happening?
Yeah, it's if we could have a breakthrough and have a very simple point of care test that was sensitive and specific and could let us know if a woman is colonized in labor, and that's been something of a holy grail, but maybe you have developed one or are close to developing one. I think it could improve some opportunities for prevention. I don't know exactly how it would fit in with a maternal vaccine, but certainly in settings that are using IAP or able to use IAP, or even in LMIC where there are a reliance on a risk-based approach, this might become an option where it would be an improvement over current risk-based efforts. I'm not sure that again, as I said earlier, I think there's room to have both IAP and a vaccine, but I'm not sure that's ultimately where the field would land. And if we have a vaccine available for LMIC, I think a lot of effort should go in that direction. But settings that can do a risk-based approach might really benefit from
Thank you very much.
Thank you very much. The lady has really begged me to give her a chance, and in the spirit of being fair, I'll give her the last words.
Thank you, ma'am. Thank you for the presentation, ma'am. I've heard so many solutions being preferred to GBS, including vaccine, anti-prophylaxis. I'm from the LMIC countries, and you'd be so surprised that some of these women over there, they have alternative medicine, natural products, in which they use naturally from the field and the likes to combat some of these things, but might not be well documented, like we have gaps in data from those places. Personally, I'm also into natural product research. For this conference, I worked on a particular plant, in silico studies and computational chemistry. And some of the metabolites, compounds from the plants, I got a lead that is very promising. So I've not really heard talks along that line, alternative search, in addition to what we have on ground. So that's I would like us to look into that aspect too. Thank you.
I think it's a fair comment, and I think that there is some effort to try to build in a little bit more study of it. I mean, you're right that if these things are never studied, they always just stay in the folklore kind of realm and don't move into science. It's tricky to know which ones merit the study, and again, to have the resources to look at those, but I think it could be important. The one I'm more familiar with from all my years of answering questions in the US from parents is garlic, or I've heard garlic mentioned often in the context of group B strep prevention, and from what I understand so far, I would not rely personally on garlic if I were trying to protect my baby, but doing rigorous studies of promising compounds might be another direction.
Thank you very much. Let's appreciate Stephanie for her lecture, for her time.